the next slide's kind of all out of here. This is probably the key on this slide, and I don't know why it's this big for some reason. Did it come like this when you looked at it too? Sorry. The acute case goes really up to the first 3 months out of surgery, and that's really because we were waiting for swelling to go down before we tell this patient, this is your injury, this is the way it's going to be, let's move on. We've got to wait for all that swelling in the spinal cord to go down. So the acute phase goes for the first 2 to 3 months after the spinal cord injury, and then they go into rehab phase, which is going to be their recovery rehab and dealing with what they've got left for the rest of their life. In terms of recognizing cues, this is probably the most detailed. I want you to go into this. I think this slide right here is probably the best visualization of what you're going to get with what's going to be left for these patients, or determining what they're supposed to be missing. You can do the big spinal exam, but I'm not testing you on the spinal exam because your patient has to be awake, alert, and responsive in order to do the spinal exam fully and completely. Some of our patients maybe, some might not, but this is probably what I would spend my time with, is what do the big gross things that happen. And you can see that everything cervical is everything up here and to your, basically your shoulders and all the way to your upper extremities. So any cervical injury is going to involve you're going to lose everything below your upper extremities, okay? Because that's where your break in the spinal cord is. So everything will up until the break, and then everything under the break is going to be dysfunctional, okay? So if you have a C4 injury, you're going to have problems with all of your upper extremities and everything below. If you have a T6 injury, you're going to have a problem with your bowel muscles and everything below it. But you still have kept intact your chest muscles and all of your upper extremities. So you can kind of see where, if this is a complete injury, where they're going to be paralyzed or where they're going to be left with some dysfunction. And so we will tell you that the key is halfway down the spinal cord. Everything above T6 is going to be at risk for more problems. And everything below T6 isn't going to have as many side effects or problems afterwards. What makes you quadriplegic versus paraplegic is going to be determined somewhere in the C6 to T4 area. The thing I'm going to show you, though, is that why thoracic injuries still have trouble breathing and stuff. Think about it. Most of you guys think, oh, well, if I can breathe, I'm doing okay. And diaphragm is controlled up there on C3. So as long as you don't have a C1, C2 injury, you should be breathing just fine. Not true, because most of your breathing isn't just your diaphragm, it's all your chest muscles. You can go into respiratory failure without those chest muscles working, right? Because when your patient got tired and their chest muscles get weak, you head into respiratory failure. So patients who are T6 and above are going to have some respiratory difficulty because their chest muscles still work. But if you're up in here, you may have problems with your chest muscles. There may be some issues. I will tell you when you are swelling. So after you've broken a finger, where do you swell? Just right over the break? The whole entire finger, right? So let's say you break T4. Where are you going to swell? And down, okay? So when you're doing an exam on this patient, what are they going to have below T4? Nothing, right? Because they're swollen there. Even if it wasn't broken completely across, maybe it was only incomplete. Maybe the vertebrae there nicked the spinal cord, but didn't completely transect it or completely break it. We're still not going to have anything below it because that area is swollen right now and nothing's transmitting through the swelling. Does that make sense? So you can't really prognosticate until the swelling goes down what function they have. You just can't. They can take you to an MRI and you can guesstimate, but until that swelling process goes down, you're going to have issues. But because of that swelling finger thing, let's say we have a break at T4, you're going to swell that. but you're also going to swell north. So in the acute phase, during that swelling period, the swelling is known as spinal shock. It's just swelling. And it means that while the spine is swollen, you're going to have different dysfunctions than when the spine is not swollen. So when that spine is swollen, you're going to have, if you broke a T4, it's still going to swell up. And it's going to look like you have a function, you have injury minor because of the spinal shock. Does that make sense? Spinal shock is just swelling. Not going to change your vital signs, but it is going to change where you're going to see function. And that's just because when you break a finger, it's going to swell for a while until it starts healing. The spinal cord does the same thing. When it's broken, it's going to swell. And so I want you to know that you will swell up to about 3 levels of height. So a patient with a T4 injury where, okay, they might have half of their chest muscles working and half of them not. Well, if they swell upwards, that's what they've lost all control of while they're swelling their chest muscles. These patients might be in respiratory failure for you because their chest muscles aren't innervated. Once the swelling starts to recede, then they will get more and more control of their chest muscles as that innervation starts to heal. Any questions on that? I think that's a very basic thing that a lot of people miss. Spinal shock is just the same as if I said finger shock after you get hit with a mallet. It's swelling, okay? And they call it shock because it is decreased perfusion, because what's happening to the spinal cord as it's swelling? Is it getting good blood flow? No. So decreased perfusion can hit the spinal cord. And while it's swelling, we're not perfusing the spinal cord as well. So we want the swelling to go away, because if you keep the spinal cord swollen, you might have some ischemic injury to there. And so not only do you have a T6 fracture that's swelling above, that might become permanent if you can't get that swelling under control, and it cuts off circulation to that T1 to T4 area. It could become a longer process. That's why we don't prognosticate until the swelling has gone down. So when your patient says, oh my God, I am quadriplegic, I don't know if I can live like this, and they have a T6 injury. Well, let's give it a couple of weeks. You might get some of that back because your spinal cord is swollen right now. And so even if you don't know everything about spinal cord injuries, you could give some hope to the patients that are in there in the first few weeks. Like, just because this is going on right now does not mean this is the way you're going to be for the rest of your life. Let's just try to keep you still, calm, perfused, oxygenated, and we're going to give the best chance for that swelling to go down so you'll regain all this function, hopefully. Cross fingers, but depending on how they do and how well you perform the interventions in the acute phase, they could have a secondary injury, which is from that swelling causing more damage to the spinal cord. So we are going to try to manage that swelling. So in the primary injury is just what broke. The primary injury is what broke. The secondary injury is what happened during the swelling process. Okay? So again, you don't need to know the difference between flexion, compression, hyperextension, flexion, rotation. Not going to ask you that on the test. Okay? That's just, you can kind of see how your cords can get damaged. The 4 ways your cord can get damaged. But what we are looking for here is that the specific cues are related to the level of injury. And this is my favorite picture, just because it really just things everything to chest muscles, abdominal muscles, leg muscles, and really helps you kind of see where your breaks are going to affect your body. I like this a lot better than memorizing all these different things because, hey, if your wrists, triceps, and hands are all still perfusing and functioning, you're going to be a paraplegic. If you've lost your hands, wrists, deltoids, biceps, then you're a quadriplegic. So, I mean, you can memorize all those levels, but I really want you to know that T6 and above, you're at more risk for these shock syndromes, like neurogenic shock and autonomic dysreflexia. Those really only happen T6 and above. And then T6 and below usually doesn't have as many acute phase side effects in terms of blood pressure and respiratory rate and stuff. There's just complete and incomplete. Again, here's just the list of incomplete. I just need you to recognize the list of incomplete. Okay, you don't need to know which one, because if you look at this grid, you might start studying way too much. I don't need you to go in and memorize this. I'm not going to ask you questions on this. I might ask you questions like the other one, where it was like, oh, you could rule those out because they weren't complete cord injuries. But you don't need to memorize which ones do what. I don't even memorize that. You can keep this grid for your reference if you like. You go work in a spinal cord unit. But this is what they're left with, but don't memorize it. I just want you to know the difference between complete cord and incomplete cord. Can we tell the difference in the acute phase between complete and incomplete? Not really. With that swelling, it's going to look complete. These incomplete cord injuries, you're only going to see them on the MRI in the acute phase. But then that's going to give you clues. You're like, oh, well, they have central cord syndrome, but they look like they're completely paralyzed. It's because they're in that acute spinal shock phase where they are swelling. And so remember, things always look worse when things are swelling. So as that swelling goes down, you're going to see their true injury. And some of these things could return. So if you have a patient with central cord injury and you have this grid, you would be looking for these things to come back on your patient as swelling went down. The MRI will tell you what kind of injury they have. And so then we can start looking for cues of recovery. But you don't need to memorize this because I really don't think this is something that you guys are going to specialize in right now. And if you do go to a spinal cord unit, you can keep this as a reference guide, because that's really what we need to know about it. It's just that if they have central cord syndrome, as that swelling goes down, you would be looking to see, did you get some movement back, but you maybe can't control it. But that would be part of what I would expect for central cord syndrome. So again, don't worry about it. But here is the keys, and here's where we're going to go back to the grid. This is stuff that is your secondary injury. These are worsening cues. We know the spinal cord is broken. We've gotten CT scans, maybe an MRI. We know where the break is. We are just watching for that swelling and the receding of swelling. Okay? If you are T6 and above, you are at risk for neurogenic shock. If you are T6 or below, you are not at risk for neurogenic shock. Let me show you why. And we'll go back and this is a very easy explanation. Basically, the vagal nerve is vagal nerve 10. Your vagal nerve is your parasympathetic system, the rest and digest system. This is not through the spinal cord. The parasympathetic nerve innervates the heart right down there, and it innervates the GI tract. Okay, it does not go down the spinal cord to do so. It comes right out of cranial nerve 10 and goes down. No, sorry, again, the 9 clavicle, so 10 is vagus. The vagal nerve, cranial nerve 10 comes out, innervates the heart and the GI tract. It's rest digest. Okay, so the sympathetic system comes out with spinal cord around T5, T6. So information from the brain to innervate your sympathetic system, meaning your speed up, your rest, your I gotta go, your fight flight, comes out of your spinal cord. And your vagal system does not use your spinal cord. So let's say you broke your T5, T6 right there, and you got swelling. So what is not coming down from the brain and going out? Your sympathetic nervous system. What does your sympathetic nervous system do? Flight, raising blood pressure, raising heart rate, raising respiratory rate, right? All that good stuff. In a spinal cord injury, you can't do it. If T6 and above swells, this area can't get out. The sympathetic thing from the brain's going, get that blood pressure up. I'm not confusing. Get that blood pressure up. But the message never gets to the heart because it comes out the spinal cord about T5. So that's where the sympathetic nervous system comes out to innervate the heart, to tell it to speed up, to increase the blood pressure, to do all that. So basically what you are seeing in T6 and above during the spinal shock time, they are at risk for losing their sympathetic tone. So they can't up their heart rate, up their blood pressure, and up their respiratory rate. And all that's left is completely uninhibited parasympathetic function. Rest digest. So what do you think you're going to see in neurogenic shock, which basically means a neurogenic shock. Everybody thinks it means brain because it uses the word neuro. It just means that the stuff from the brain can't get down to the body. Neurogenic shock means your spinal cord is swollen and your sympathetic cannot communicate with your heart and your blood vessels. So during that period, what are you going to see? Your sympathetic system completely shut off and your parasympathetic system running rampant, meaning your heart rate's dropping, your blood pressure's dropping, your respiratory rate's dropping, because the heart and the lungs are getting a signal from the brain to just chill and rest and digest, man. Life's good. You just be chilling. So they're going to have hypermotility, a lot of saliva production, and a low respiratory rate, low blood pressure, and low heart rate because your fight is broken. And that is neurogenic shock. So let's go back to our grid and we'll talk about neurogenic shock. So what causes neurogenic shock? What level? No, neurogenic shock. Yeah, right. Neurogenic shock has to do with the brain. Neurogenic shock does not have to do with the brain. I'm sorry. I wish I could name things. But what is this caused by? And above during swelling. So during that time that you are swelling, the sympathetic system can't work. Once the swelling goes down and you're back down to just maybe a break or something, that sympathetic system can find its way around and figure out a way to re-innervate the heart. But until then, in that acute phase, they may be in neurogenic shock. So T6 injury and above during swelling, what are our cues? Decreased blood pressure. Everything's decreased. This is a true shock. Decreased blood pressure, decreased heart rate, and decreased respiratory rate. Okay, so we know now that neurogenic shock is not Cushing's triad, and it is not involving the brain at all. It's involving the spinal cord. T6 injury and above, and that is just during swelling, and I'm going to say causing no white, pure rest, digest. So basically, and you can use whatever words you want. You can change this. This will be a Word document. So if you understand sympathetic and you want to use sympathetic in there, but basically causing no sympathetic innervation and pure on 100% rest digest. And that's why everything's dropping. So what do you think we're going to do for neurogenic shock? What do you want to do for the blood pressure, heart rate, respiratory rate? How are we going to fix this? So fluids. What are fluids? Fluids going to help? Why? Because why is our blood pressure so low? Why is rest? What has it done to drop our blood pressure? What does the parasympathetic system do? It causes vasodilation. So yeah, we might need to, can we do a nursing intervention here? Let's do nursing and let's do ordered. So what do you think? Can we do for that blood pressure?
We did.
So I think that your best thing, yes, with a decreased blood pressure, well, they should be anyway because they're a spinal cord injury patient. But yes, had a good flat or so spinal cord injury. We're not talking about head injury. Now, if they're both, they get a little more complex. But with just a pure spinal cord injury, no blood pressure, you can drop the head of the bed. But you got to keep them flat, so you'd have to do Trendelenburg. So you drop the head of the bed, that will get blood flow to your brain and to your thing. Now, you have to watch that if you had a head injury along with it. But we're talking about pure spinal cord injury, fix the blood pressure. Yes, you could do the head of bed flat, which you know, that will help your blood pressure. What will help your heart rate? Anything? Probably nothing we can do nursing wise unless we walk in the room and go boom. But even then, it won't work. It won't work because what makes your heart rate go up when I say poo? Your sympathetic nervous system is broken. So even me going in the room and going, isn't going to do anything. Me going in the room and giving them epi might not do anything because what does epi work on? Your sympathetic nervous system might not work. So I think that's the best that we've got right now is head of the bed flat and Trendelenburg. What can we do for that decreased respiratory rate nursing wise? I can't do anything without the heart rate. There's nothing I'm going to do to stimulate them is really going to work. Anything we could do for the respiratory rate? Say our respiratory rate's 4 or 6. What do you want to do? If the respiratory rate's dropping, we can bag the patient. Yeah, let's do maintain airway. Bag patient. Yes. Oh, whoa. What do we bag the patient for? So if the respiratory rate is not adequate, we need to make it adequate. So if we're just looking at what we can do as a nurse without any orders to help our patient, I think this might be the most of our list there. I can't really do much else for the decreased respiratory rate other than bag it. I can't do much for the blood pressure except for the head of that flat or Trendelenburg. I really can't do too much else. So that's probably what we got for quick nursing interventions. So what do you think we want to have ordered? What do we want to anticipate the order? What orders do we want?
Do you want vasopressors?
What do you think? What vasopressors do we want?
Treat it like it's Brady, right? Yeah, so like you don't have Brady heartache.
I know. We want atropine. Why do we want atropine? You're right. Treat it like a Brady. It is a Brady. Why is it going to work?
So it bypasses the override estimates.
It overrides the parasympathetic system. It blocks. It's an anticholinergic. Atropine is an anticholinergic. Anything cholinergic is your parasympathetic system. I used to say this in my lecture in block 3, but that's why the parasympathetic stimulates your colon. It's the rest and digest. And so cholinergic is your parasympathetic system. So an atropine is an anticholinergic, blocks the parasympathetic system. Do you think that would be helpful in this situation? Let's look at the picture here. Where'd my picture go? This one? So, this one. If we're dealing with this problem here, and our sympathetic nervous system is not working, our parasympathetic system is just going unchecked. Well, you know what we need to do? We need to check it. Stop. It's too much. You're dropping the heart rate, the blood pressure, and everything. Too much. Why don't you take a little pill, take a day off? We're going to give some atropine and tell you to shut up. And that's basically going to up your heart rate because it shuts off the slow down signal. So atropine works great, and it's probably the only thing that is going to work. Think about your other vasopressors. What are they? Let's go back to our thing. What are your other vasopressors? So number 1 is going to be atropine. Number 1 is going to be atropine because it will fix your heart rate. So think about your heart rate. Maybe your heart rate's now at 48 or something. Atropine, you're going to give it. Your heart rate's going to come up to 60. What's going to happen to your blood pressure? When your heart rate goes from 48 to 60. It's going to get better because, hey, you're putting out 100 milliliters every beat, and you were putting out 50 beats. You're now putting out what were you putting out? 100 milliliters per beat for 50 beats. You're putting out 5 liters. It's probably adequate. Let's say you're putting out 100 milliliters and this heart rate's 40, like 4 liters per minute. If you go up to 60 beats per minute, you're putting out 6 liters. You're increasing your cardiac output just by increasing your heart rate. So the reason the blood pressure dropped was vasodilation, but it's also decreased heart rate. When we increase the heart rate, we get increased blood flow out of the heart. Does that make sense? There was no problem. This patient doesn't have CHF as far as we know. They just lost their sympathetic tone. They lost their ability to raise their blood pressure to vasoconstrict and keep the heart rate up. So we give them atropine, their heart rate shoots up, and so does their blood pressure reflexively, because we just increased the amount of fluid coming out of the heart. By increasing the heart rate, the blood pressure should get better. Also, the atropine will block the vasodilation that's happening out there and cause a little bit of reflex constriction. So atropine usually helps your blood pressure, not directly, but indirectly by upping your heart rate and stopping the vasoconstriction. Okay, and then we'll just kind of titrate how they're doing, and they might need multiple doses of atropine to get them under control. But then we can also give what else to keep those blood vessels filled? We can give fluids. There is a caveat, though, to be careful with fluids because we don't want to cause more swelling in the spinal cord. So yes, we can do fluids, but we have to be kind of careful with them. We don't want to overload the patient because that will cause more swelling and more, tissue edema. So we're going to give atropine and fluids. Think about some of the other meds that we might want to do to up your blood pressure. Would they work? What meds do we usually give to up our blood pressure? Well, albuterol will up your heart rate, but we're also giving it for a reason that it doesn't need to be given. So albuterol also open the airways, and we don't really have an issue with the airways at this point. So it wouldn't do anything to your respiratory rate. Basically, the respiratory rate we are going to have to manage with either just letting the patient have lower tidal volumes. We're going to have to try and get them to breathe bigger, breathe deeper. But if they're having trouble breathing and they're in respiratory failure, you're going to get intubated. It's just, if you're not breathing well, we're going to have to take over that for you. And because we have to maintain oxygenation and airway, do you think they're going to get BiPAP with a spinal cord injury or an intubation with a spinal cord injury? More than likely intubation, because they probably are not managing their airway well enough for us to be sure that they're going to get adequately tidal volumes and adequate respirations. So on this patient, they might do BiPAP for a while, but he might end up needing to be intubated. If they are swelling to the point that they are having decreased blood pressure, decreased heart rate, decreased respiratory rate, the only way we can fix a respiratory rate is really by going in there and changing their respiratory rate, which is going to require intubation probably. They may be managed on BiPAP, but on high level spinal cord injury like that is susceptible to neurogenic shock, is probably going to be intubated so that we can manage their respiratory rate by just increasing respiratory rate on the ventilator until they pass through neurogenic shock. So atropine fluids, and we're going to say mechanical ventilation. Because if you are in neurogenic shock with a decreased respiratory rate, you can bag them for a while, but they will end up in respiratory failure if they're not adequately respiring. So probably mechanical ventilation, whether it's non-invasive or invasive. And I think that's it for neurogenic. Yeah.
Is this like an emergent event where they need like electronic pacing, or is this?
So yes, that is a great, they may, true. They don't want to do it as pretty intervention, but I will add that as if you cannot manage it with doses of atropine, you may have to pace the patient for a while. They may have to do it. Now that's a pretty heavy intervention because that means you either have to put in a central line and pace temporarily through the actual, or you have to put in a pacemaker. So it's a pretty big intervention. Neurogenic shock may ebb and flow during that whole acute phase, depending on the swelling of the spine. You may have it consistently. It may just ebb and flow. So all of a sudden you'll have a drop of blood pressure, heart rate, respiratory rate. You have to do a few things, and then they kind of come back and control it for a while. And then maybe you give too much fluid, they drop into neurogenic shock again. And so it's kind of coming and going, just like we're watching the ICP constantly. We'll be watching kind of what the respiratory status looks like. And again, because these patients that are prone to this are T6 and above, it is going to affect their chest muscles as well. These patients are not breathing real well, especially during the swelling phase. Yes.
The quadriplegic I know said that it was really scary because initially he was breathing on his own and then he wasn't able to. And like the whole process of going through this was absolutely terrifying. So if you're dealing with it, remain really calm for them.
Yeah, I mean, like, honestly, and the reason, if I can tell you what's going on and I can explain to you and you can explain to them, this is temporary during the swelling phase, and this is just because everything's kind of off kilter for a little while until the swelling goes down. But we all know swelling lasts up to a month, depending on how much we're cleaning up and fixing. So spinal cord injury is going to be swollen for a while. But yes, that will help definitely your patient care. And the reason I teach you all the whys is so you can explain to the patient. If I tell you at a very basic level what's going on, you can share that basic level of what's going on. And you just tell your patients it's temporary. Things may get better, may not, but it may. Give them some hope. But really, this is what we're dealing with in neurogenic shock. It only happens during the swelling phase, and it causes no sympathetic stimulation, overactive parasympathetic stimulation. So what we're going to do is really treat it as a Grady and try to support the blood pressure and respiratory rate. But really, the only way we can do that is with ordered interventions. Okay, there's not much we can do nursing-wise. But if you noted your patient going into neurogenic shock, you're not going to be surprised based on their level of injury. You can go ahead and get those emergency interventions and get your call off. And they might even have these orders as standing orders in your chart because they know the risk is there. So you might have atropine as a standing order. You might have fluids as a standing order. But that's neurogenic shock. Spinal shock. What is spinal shock? That's it. That's all it means. The cues are that you will lose complete function below the level of injury. That's a given, below the level of injury. But it could be an incomplete injury that is swollen to look like a complete injury. So during spinal shock, that your cue is that you're in spinal shock is you have complete, no sensory below the level of injury. That's spinal shock. As the spinal shock resolves, which will happen in the first month, then you may see whether this injury is complete, may retain complete loss below the level of injury, or whether this was an incomplete and they're gaining some stuff back below the level of injury. But during the spinal shock phase, it's just swelling. So you're going to lose complete function below the level of injury, and you may swell up to 3 to 4 levels above the injury. And that's the dangerous part. We know, okay, that's below the level of injury is either gone or partially gone, depending on how much damage there was to the spinal cord. But the danger is the swelling up. And that is what we're watching for, because if you swell up to 3 or 4 levels above the injury, then that could cause some pretty big problems. Let's go back to our PowerPoint and look at our beautiful little, where's our little fun slide? This slide up here. Let's find the bigger picture of it. I love this spinal cord. You can tell it's on multiple slides. When I love something, I just reuse it too much. But let's say you have a T3 injury. What have you lost below it? Most of your chest muscles, your abdominal muscles, your leg muscles. So what do you think this patient's going to look like to you at a T3 injury? Quadriplegic, paraplegic. Paraplegic means just your legs. Two paralyzed injuries. You know, in England, they call it, instead of quadriplegia, they call it tetraplegia. Tetra means 4 as well. I think one's Greek, one's Roman. I don't know, but of course they have to be different. So they call it tetraplegia instead of quadriplegia, but I think para is the same. Anyway, T3, we have lost all this. That's a given, or it won't be very functional. But during the spinal shock phase, it's all gone. So that means this patient is not breathing adequately. They're probably not moving. They can't sit up. It's your abdominal muscles. How do you sit up? Is with your core. These patients, if you sit them up, they're just going to poop right over. They have no abdominal, they have no core strength. None whatsoever. So they lost all that. But the dangerous part is swelling up to 3 levels. You could lose your hands. And that's something when you tell the patient, this is spinal shock. It will be swollen for up to a month. You may get that function back. You may get your hands and your triceps and your wrists back. You may have function. They may only have this function. They only got triceps, and whether they can pick up their arm, but they can't do anything with the rest of it. And you can tell them, hey, you're swollen up. So that's okay. Let's just wait, calm down, give it a month. You might get some function back as that swelling goes back down. But if you are at a T9 here, basically your kind beak is sitting up, but you should be able to breathe just fine. Your chest muscles are intact because you're at a T9. So a T9 is going to have some bracing issues, and you're going to need to stay straight. You're going to have bowel bladder issues. You're not going to be able to use your legs, but you should keep your core straight. But what if you are a did I say T8, T9? What if you swell up into the chest muscle area? Now, all of a sudden, maybe they're having a respiratory rate of 40 and shallow respirations and accessory muscle use. You need to be aware that even though they're a T9 injury, they could be swelling upright to involve their chest muscles. It's not involving their diaphragm, that's way, way up there. But if you have maybe a C6 injury, what could you swell up to? You could swell up all the way to your diaphragm and lose your diaphragm function. Like, that's a big thing to know. You're like C6. Oh, that's just your hands and stuff. You're good. You can breathe. Not if that swelling goes up to that level, then all of a sudden they've lost their diaphragm. And if they lost their diaphragm, they can't really pull air. So you're going to go and respirate. So always be watching for patients that have issues T9 and above. You can have respiratory difficulty as they're swelling. So that's the one thing I remember you about, to remember about spinal shock is just know that some of that swelling could go upwards, and you may have symptoms you're not expecting unless you know what's a couple of levels above. So when I give you a patient that has, maybe a T7 injury, I would want you looking for chest muscle problems during the acute phase, during the spinal shock phase. So hopefully it's not too unclear, but basically what spinal shock just means is that you could lose complete function. The other thing is that we said neurogenic shock, T6 injury and above, but what if you had maybe a T7 injury? You might swell into the level that might give you spinal shock. So I want you to just be aware of kind of what the general muscles do. You don't have to memorize the slides that tell you all the spinal assessment. Again, this stuff, this is definite. It's all highlighted, underlined, all that good stuff. Definitely you need to know that. And again, I summarized it there. That's the same slide, just summarized different ways. You don't need to worry too much about the temperature dysregulation. That is part of it. But really, if you know hypotension, bradycardia, peripheral vasodilation, those cues will be on there. There may be a cue that says they can't keep their temperature up, but that's not a specific cue, so I'm not going to put that too much in a highlight. This I'm not testing you on, but this is really how if your patient's awake alert, this is how they decide level of injury before the MRI scan. If your patient's awake alert, you will go down the dermatomes and you will do either pinprick, alcohol swab, and you're basically going each level to find out where they lose sensation. And that will give you kind of a level of injury. I don't need you to memorize this because this exists everywhere as a reference guide. But basically, and you can't really do this on a test level. And I don't see the point in making you memorize all these different levels, but they do correspond to those chest muscles, abdominal muscles. But if you lost function right below your rib cage there, and that's where, like, basically when I couldn't feel you doing a difference between cold alcohol swab and pen prick, or, sometimes they'll take little needles and just kind of do a little poke to see where they're feeling. But if you lost it right about here, you'd be at T7. And so you can kind of guesstimate, but it doesn't work during spinal shock because that could be 3 or 4 levels. So I just want you to know that during that spinal shock phase, you may have changes in your sensory and motor that are above your level of injury, and you won't have anything. So you've got to keep doing this as their acute phase goes away, because you're going to be looking for return of function as well. Most patients are looking for return of function. They're desperate for return of some function. And we tell them, we're going to be checking you every day, but this is what we're looking for. And so they're waiting for it. I mean, if they're awake, alert, and they're waiting and they're looking for return of function, and so are you, because we are hoping for that in the first few weeks. So let's take a little break. We'll go into autonomic dysreflexia when we talk about, I'll go through the interventions and then we'll talk about an autonomic. But I think you have a little bit between the brain, there's only one set of cues, and it's increased ICP, because the brain is its own thing. The spinal cord is its own thing. So nothing in the spinal cord is going to up the ICP. The spinal cord is separate. If you have a spinal cord injury, it does not affect your brain. The only way you get increased ICP is from a head injury. So you would happen to luck, you have a head injury and a spinal cord injury, which makes our interventions a little bit trickier. But we're just going with the black and the white. If it's a spinal cord injury, it will be a spinal cord injury. I'm not going to mix the two patients for you on the test, because that gets into like, no, ICU. We're not going there. So the patients will be clearly spinal cord injuries or head injuries, and they will be separate. So why don't we go to lunch? Come back at noon, and that way you'll get a little bit of food in your head. We will review real quick the spinal cord thing, and then we'll do some patient scenarios that maybe help you realize the intervention. We'll fix the rest of this grid after lunch. Any other questions until then? Let's get some food, refresh your brain. Oh, give it some glucose.
I'm just so scared.
Oh, thank you. I'm going to pause. Thank you. So I'm going to show you the, at the bottom here, I have a log rolling and spinal precautions little video for you to watch. This is an extra supplemental PowerPoint. I should have put them all together. I meant to do that this time around because we used to do trauma skills, and we would kind of come through here and have you guys do log rolling. Who's done log rolling? Anyone? 1, 2. That's it? All right. We might have a demo on log rolling.
I've been rolled too.
Huh.
I've been rolled too.
We used to have a trauma skills, and I still may do it so that you can practice log rolling your patient, but it does require at least 3 people, at least 3, probably 4 for the best practice. Yeah, you have done log rolling. Most people have done log rolling. It does involve 2 people to turn, 1 person to be on the head. The minimum is 3. And more than that is helpful. But basically what they're doing, we could bring people up to the front of the room and roll them. We've done this multiple ways before. I can bring the mannequin in and roll them if you want to practice. Or we can go down to the lab after class if you want to practice log rolling. But what someone is going to do is either you have them in the collar and you leave them in the collar. But if you are taking their collar off, which you can do, you have to keep the head immobilized. But if they have their collar on, then usually 1 person is up at the head, just making sure that the head stays in alignment. And if you are looking from the head down, you're in charge. Whoever is standing up at the head, to see a pair of hands there up at the head, they are just in charge of basically holding the head. I do need to bring a mannequin in here. They are in charge of holding the head. Who wants to be a person? Here. Come on up, Aaron. I'm not going to put you on a thing, but basically, I'm just going to show you the whole process. Sorry, this is mine. This is only on me or mannequins.
All right, follow my food.
Yes. So, this is not a tight collar. It's not well placed. But basically, this is going to hold her head. So, can you bend your head down? Well, you shouldn't be. If this was tight, you should not have your range of motion. All right, that's here. But I'm just going to show you the hold. But basically, this should go under the chin here. It should be sitting right under the chin, and it should keep your range of motion. You shouldn't be able to bend your head down, back, or side to side. You can move a little bit, but you shouldn't be able to swerve your seat line. If she has a lumbar thing, we still want to keep the cervical spine straight because remember, if they are in that thoracic region and we have swelling up, we're still going to keep this area straight. If you are log rolling, dear Erin here, what I would recommend is giving your hand to grip, and you want to grip right in here. And if she was laying down, her head would be right between my forearms, and you're going to grip the shoulder right at the pad. And if she was laying back, her head would be between my forearms. You're going to use your forearms as another way to keep the head from moving back and forth. So you're going to put your shoulder down, put the thumbs right here, and hold on to the shoulder blades at the back, and then her head is on either side of my forearms, and that will be the head person. That's all you need. Thank you. But we will bring, maybe I'll bring the mannequin in or kick you guys down at lunch. But what you're going to do is the person on top is going to be holding that C-spine. It is very important that if you take the collar off, you can only hold that. You are the collar. So if the collar is off, you become the collar, and you are holding the head from moving back and forth with your forearms. Heads weigh about 10 pounds. They're heavy. They're like a bowling ball. So if you are the person that is turning and holding that head, you are the bowling ball that's you're holding that bowling ball. So your arms are going to get tired. So make sure that if you're log rolling and if you're like turning them to do a bath or something, or get the sheets out from under or anything, you may be holding that head for a while. And you think the collar is going to be great. The collar is great. But as that head is off to the side and off the pillow for a while, it's going to start weighing more and more and more. And you'll see where that head starts dropping more and more on your bottom. So you want to be able to keep that head from dropping to the side. So the log roll person is at the head of the bed. That's the person that is maintaining cervical connection. And then you have the two people rolling in unison. Because if there are two people, one on the butt and one on the chest, you can turn at different rates. We're not going to twist the spine. So here, what you're going to do is you're going to overlap arms. So one person is holding butt and shoulder. The other person is holding back and back of the legs. And you are turning in one. The person on the head counts 1, 2, 3, and everybody turns on 3 because the head person needs to be in control to see, you want to turn the head first and then other people turn the body. You are rolling in a unison. The head person counts, they count to 3, everybody moves as one, and you keep the body straight. Head person, if you're looking at someone's head, you are aligning them and making sure they're aligned. We use the very, very pleasant nose to nuts. Keep the nose all aligned to the nuts. And if there's lady parts, nose to lady parts. But basically, that's where you're trying to keep that head in alignment. And so as you're turning the head and you're turning the whole body, make sure that nose stays in alignment because you're trying to keep the neck and spine as straight as possible. So that is log rolling. We do have it, before we used to do disaster day, we would have everybody practice it. What I would probably do is bring a mannequin in someday, for next week when we're doing the ER stuff, we will probably be practicing a little bit of that. But log rolling is one of your key nursing interventions for keeping that spinal shock from getting too big. So we are going to do spinal immobilization with a collar and log rolling. You can remove the collar. So let me put this on me. You can always remove the collar for hygiene care. Okay. So a lot of people will come in neck and back and they'll be wearing their cervical collar. And we spend days doing back care and all that stuff, but nobody's ever removed the collar. And so when you finally find someone brave enough to take off the collar, and they take off the collar and glass and blood and all the stuff from the accident is still there because nobody took off the collar to do any hygiene. You may take off the collar to do hygiene, but what do you need to have? If you're going to take off their cervical collar, you need cervical immobilization. So what we tell people to do is if you're going to take off their collar, have someone else be holding their head in alignment. So someone needs to be there doing the head thing. And then once they have that stabilized, You can take off the front of the collar, wipe the neck, but someone is holding neck stabilization while someone is doing hygiene. You're not going to do this on your own. Don't take a collar off without someone holding that neck stable. So that if your patient decides to turn their head to see what you're doing, they've got their forearms to either side of their head and they're keeping their head straight. So when you take the collar off, they need to be in some kind of hold in order to keep their neck straight. Does that make sense? So you may take off your collar for hygiene, but do not unimmobilize them. They should be staying in a straight line. So they will be having a seat collar, they will be log-rolled, and only a physician's order can discontinue log-rolling, cervical collars, and braces. Okay. So yes, if your patient is in spinal precautions, that means log roll them and leave their collar on, unless you have an order to do otherwise. But that's where a lot of people are like, I'm not really sure what I'm supposed to be doing. They came in with a spinal cord injury, but I don't know what spinal precautions means. It means collar and log roll. And then if you're not wearing a collar, you need to have your immobilization and log roll. They can be removed for hygiene. Please remove the collar for hygiene, but then put it back on. Make sure that you do not leave don't take the collar off and expect the patient to be able to maintain their own neck, just like you wouldn't take a cast off and not have something else to splint the leg. It's the same thing. So maintain spinal stability. That's the number one thing you can do to keep the spine from swelling more. Because when something's broken, it will swell if you put weight on it. So we can see that there's a lot. This is one of the kinds of collars. There are tons of different kinds of collars. The doctor will order them. That's just for your reference. And then if you have a thoracic or lumbar, you may get a brace as well. Depending on what's involved, the brace, whatever's involved. Once you have a brace, you may then probably stop log rolling. But I would admit an order from the doctor that you don't need to do spinal precautions anymore. And spinal precautions mean collar and log roll. So if you would like to have no collar, they have to discontinue spinal precautions. Or you have to be out of the swelling phase. Don't come off spinal precautions while they might be swelling from a spinal cord injury. You need to have the braces on to keep things from swelling more. Then we're going to put in secondary damage and swelling edema, because if your spine swells and stays swollen, it can cut off circulation to your spinal cord. We want it healing. So this is oxygenation and perfusion. So open airway, neutral head position. Well, if you got a collar on, you're already on that because you've got your airway. You can maintain your airway because this is holding your airway, right? It's holding your airway stable. What do you do if you have to code this patient? What do you do if you code a patient in a seat collar? How do you get their airway? How do you normally get an airway? You hyperextend the head. You do a jaw thrust on spinal cord injury patients. You can't put their head back to open their airway. So the only way to open their airway, you put your fingers, you feel right below your ears. Right below your ears, there's a little piece of your mandible there. And it's gonna hurt. It doesn't go easily, but you can push your mandible forward, and that's the jaw thrust. It's not going to be easy to do. It hurts because there are muscles keeping your mandible attached. But to do that jaw thrust, it really hurts. I can't do it. I'm testing. But the jaw thrust is where you take the mandible underneath the ear. You physically put your fingers underneath the mandible and push it forward. You're pushing that lower mandible forward so that you're opening the airway. It's a little bit of a difference. I'm not going to have a test question on it, but just in case.
Do it with the collar off or on?
On. Yeah, we're not gonna take the collar off for coding because they're gonna be like, you think you're gonna just ruin everything that they were trying to prevent. So they do sometimes code, especially if they go into severe neurogenic shock. They might code, and that's where the difference is. You're going to be jaw thrusting rather than head back to get your airway. But most of your airway is held by the collar. That you might need to do coughing, deep breathing, mobilizing secretions. So we can put under our nursing interventions on our slide here. For our nursing, we can collar, log roll. We can mobilize secretions. And I'm not going to put maintain airway because you're going to have a collar. You know how to maintain the airway. But maybe we could put on there jaw thrust. So yeah, basically there's one difference there, but I mean, you're not going to probably need jaw thrust just in general nursing care of your patient. But just so you know, if they are in a if they are in spinal precautions and they code, the only way to really get their airway is that jaw thrust. You can't put their head back and get an airway that way. So we've got basic secretions, keeping your oxygenation, jaw thrust. And that's all important for spinal shock, because those are the things that we're going to do nursing wise. We could possibly need mechanical intervention if we're not breathing properly or getting enough oxygen. Maintaining spinal perfusion. Here's where we want to keep our mean a little bit higher, because we want to push some blood into that spinal cord space, but we want to make sure it's not too crazy high. So we're still going to keep, and this is not a guarantee, you can 70 to 100 is probably fine, but I just want you to know they like to elevate it a little more in order to get that perfusion to the spine. It's not a guarantee, like that's not a butt clench number or something, that we just want to maintain perfusion. So a normal map, and within our normal map, which is 70 to 100, we'll keep it on the high end of that map. So they might keep that map 80, 90, somewhere right in that range, somewhere on the higher end of normal. And just that's the careful. Extra fluid can cause further cord swelling. So how do you think we are going to keep the spinal perfusion going? What do you think we're going to do for their blood pressure to maintain their perfusion? What do we need? This would need to be ordered. What will we do if you have we want to perfuse, we want to maintain perfusion. So we can still do the same things we did in Cushing's triad. We want that neck in neutral position. And our ordered things to maximize perfusion. Hey, guess what I'm just going to do over here is I'm going to copy paste. We're going to take out the stuff that doesn't apply. Well, we want to map 70 to 100, but we like to keep it on the higher end. So we'll just change it a little bit. But we're not going to worry about our minimum map because we're not worried about getting to our head. We don't have an ICP issue because we have a spinal cord injury. So now we're down to our interventions there. But what do you think we're going to do to maintain that higher map? Do you think we need vasodilators? I don't think we're going to be hitting the vasodilator thing. You might need it, but mostly they will use vasopressors to try and get your blood pressure up a little bit. They do want to bring your blood pressure up a lift to maintain perfusion. So they may need fluids or IV vasopressors, which are going to squeeze down and cause you vasoconstriction. So that's maximize perfusion. It's not maintaining, we're going to maximize it. And then for maximizing oxygenation, we've got the open airway nursing wise. And for oxygenation, we can always go to, if they're showing signs of respiratory distress or respiratory failure, we can go to mechanical intervention. But we're going to make sure that they get oxygen. We'll need orders for that. So let's just we can put that back in neuro too. We're going to get oxygen. I think I need to put that under neuro too, because that's the same thing for neuro. So you can see how we're basically taking your PowerPoint and making a list of interventions for all these things. I'll clean it up for you later. All right. So what's next on our list? So we're going to immobilize the patient, maximize their secretions. We're going to see if we need any fluids or pressors to keep the mean up. We're going to keep the heart rate greater than 60, which just means watch for neurogenic shock, and if it happens, treat it. We kind of talked about neurogenic shock and what we would do. How do you get that heart rate greater than 60? Well, atropine or pacing. We kind of already covered that, but we do want to make sure the heart rate stays above 60 because that's a sign of neurogenic shock if the heart rate's dropping below 60. So that's something we definitely want to stay. And then vagal stimulation. What is vagal stimulation? What's going to stimulate the vagal? We showed you how to shut it down. Atropine will shut down vagal stimulation or parasympathetic. What will, how else do you avoid stimulating your rest digest nerve? What stimulates it? So they There were maneuvers we did when your heart rate was too high. We wanted to get the heart rate slower. We wanted to stimulate the vagal system. There, what was it? Bearing down. Number one, holding the breath. All those things are vagal stimulation. So if your heart rate is low, don't do them. If your heart rate is fast, you can try them. Bearing down and holding the breath will drop your heart rate a little bit. So we are going to avoid it. And one of the things that does do that is suctioning and coughing. Sometimes that can vagal your patient down because when they're coughing, they're bearing down. And so sometimes that stimulates a vagal nerve. So we're going to try to avoid doing things that are going to drop their heart rate because they're at risk for a dropped heart rate anyway. If they're at that T6 or above, if they're like in lumbar injury or a sacral injury, no, they're not going to be affecting their breathing. Their heart rate's not going to be affected. It's not going to be an issue. But if you see your heart rate dropping, that is a sign of neurogenic shock, and you might want to keep an eye on it and treat it the way it's needed. But we're going to maintain the perfusion by keeping the blood pressure and heart rate good. Bladder, bowel. Every spinal cord injury is going to have bladder, bowel injuries. Okay, or bladder, bowel, bladder, bowel problems. So this is kind of common sense. A neurogenic bladder or bowel just means that there isn't good sensation of your bladder and because it's broken. So this is going to happen during the acute phase. You're going to have to deal with the fact that your GI system is not really fully in effect. Now, the parasympathetic system is telling it to just go, rest, and digest. But it's a muscle. It's a muscle. And so then you have to kind of look at to see whether the bladder bowel system is actually working. It is a muscle. You might have hypoactive bowel sounds. It needs innervation from the brain in order to have the correct motility. So some spinal cord patients might not have good motility, depending on what's being told to them from the brain. So they may have a blockage of motility. If the brain can't stimulate it to go, the parasympathetic system usually keeps the bowel moving pretty good. But you can have problems during that time of swelling and issues where things aren't working properly, the reflexes aren't working properly. So always be looking at your bowel and bladder system to see if they are functioning. You can develop an ileus, which means the bowel isn't moving at all. And the treatment for an ileus is NG tube. You learned that in block 3. They are trying to prevent constipation on them because, again, the innervation to the bowel system may be hyperactive, may be hypoactive. It depends on what signals are getting through. But if you can see that every single bowel injury is going to have some issues with bowel and bladder because, where's bowel and bladder? Way down there in the sacral region. So this is where the bowel and the bladder are innervated, is down at the tailbone. So any injury above here is going to cause bowel and bladder issues because every injury below, something's missing. And so every spinal cord injury is going to have bowel bladder issues because it's at the bottom of the nerves coming out of the spine, and they are usually affected. So unless you have just a sacral injury, which you're not going to be in the ICU for a sacral injury. After I had a baby, I had a sacral injury. The doctor, I went to the chiropractor, and he's like, when did you break your spine? And I'm like, never? What are you talking about? And he's like, oh, well, you got a broken S2, S3. Really? Huh. The baby broke it on the way out. So I didn't know. I never did. I got a spinal cord injury. Sounds much better to say, hey, I'm a spinal cord. No, it's just way down there at the very bottom, and bowel and bladder were coming out above that. But I mean, really, that is every single spinal cord injury is going to have bladder and bowel issues because of how low on the spinal cord it is. They're always involved. So we do have to not ignore them, even though we get more excited about the neurogenic shock and the spinal shock. But we can't forget the bowel and the bladder. They are going to be affected. Most of the time in the acute phase, they're just going to get a catheter. Just going to get a catheter, and that's going to deal with the bladder function. Bowel function, we may have to kind of take a listen to and see if there are, what our bowel motility is like. and making sure that they are getting adequate food and hydration, depending on what their bowels can do. Yes.
If you get a bowel obstruction, could that stimulate your, like, agitate your
Yes.
nerve?
Oh, yeah. 100%. If you get a bowel obstruction, yes, that's going to cause, could be that autonomic dysreflexia. Could cause neurogenic shock when the whole system's not equilibrated yet. So always be looking out for your bowel bladder function. Again, fixing these things is not going to really affect your spinal cord, but it will keep your body all working properly so that you can heal. Because if you can't get food into your patient, they're not going to be able to repair their spinal cord, which is why really most patients in these acute phases, we need to make sure they're eating or somehow getting supplemental nutrition. If your bowels are working, an NG tube may be used. They could be just eating, depending on how they're breathing. I don't know, but just keep an eye on the bowel or bladder function because it is going to be dysfunctional. It's not going to work right, especially in the acute phase. We want to make sure, again, that we're stressing them because if you get febrile, it can increase the swelling, right? It's going to increase edema, leaking, so we go with fevers and things like that. So make sure that they don't get hot or too cold. The skin care, definitely roll them every 2 to 3 hours, okay? Please find your patients. I don't want any test questions saying, leave my patient alone for 24 hours. Don't move them. Bad idea. Bad idea in life and bad idea for the NCLEX. Turn your patients. The only reason you wouldn't turn your patient is because they flash every time you turn them. Most patients don't do that. I mean, the only time we try not to turn patients is because they are so unstable. If we turn them, it'll affect their blood pressure. That's the only time you're not allowed to turn your patients. But we should be fixing what the issues are. We know what's going to drop your blood pressure in a spinal cord injury. It's neurogenic shock. Get them the treatments for neurogenic shock and continue turning them. Don't just let them sit. They will get bed sores. So that's pretty much, I mean, really, the only thing we can do to prevent spinal shock, that's it. Okay, that's it. We're log-rolling, mobilizing, jaw thrust if needed. There really isn't much else we can do in terms of affecting spinal shock. The swelling will be reduced by making sure we hold them stable, straight, and then make sure that they're getting adequate oxygen and circulation. Then we just let them heal, okay? We just let them heal. And that's what we're gonna wait for, is for that swelling to go down. So minimal interventions and just trying to keep them perfusing and oxygenating while they are first healing. Once they go in to have full-time immobilization done, so let's go back to the PowerPoint. Oops, go back to the spinal PowerPoint. When we were talking about immobilization, there's also surgeries they can go to get the spine immobilized internally. Just like if you fracture your leg, you can go in and have open reduction, internal fixation. They can fix the bones internally. They can do the same thing, but they won't do it for the first week after surgery usually because there's too much swelling in there. They're not going to stabilize the spine until that swelling's gone down and they can kind of see what they're doing in there. So again, that spinal stabilization surgery may not happen for a couple of weeks after the accident. So we will be in cervical collar and log-rolling them until they can get to further either spinal immobilization or get them into a permanent brace that they're going to be wearing until they heal. Most people are wearing cervical collars or thoracic braces for how long? How long do you heal from an injury? How long does it take for a bone to heal? About 6 to 8 weeks. So honestly, that's what this is. It's a cast for your spinal cord. You can't really cast the spinal cord. I mean, you do have to buy casts, but this is the way that we cast the spinal cord, or with braces or collars. So think about it as a broken bone with a very delicate nerve tissue inside that broken bone. And if you break a bone, we splint it to keep it from swelling. We can't elevate our body. Like you can elevate an extremity that's swelling. We can't elevate your whole body. There's no way to position it so you can elevate your spinal cord. So we just have to kind of do general all body things, which is stabilize it the best we can, log-roll your patient, maximize perfusion and oxygenation. That's really all we can do for spinal cord injuries. We're not going to worry about rehabbing them. We're not going to worry about getting them up and moving or doing anything. We want them resting and recovering. And that means they can get up and move around after they've been cleared by the surgeon to no longer have spinal precautions and they have their proper testing on. Okay, whether that's a brace or a collar, or however, once the doctor determines that they have been properly tested and stabilized, then they can start moving around. But you want to make sure that they are stabilized first, because that is the biggest intervention for getting rid of spinal shock, is immobilization and maximizing. So then we head into the rehab phase. So we kind of kept them all stable. We did all these great interventions, and we've gotten them into, they've gotten to their healing point where the swelling should have gone down, the bone should have healed. Okay? This is where you're going to live for the rest of your life in this rehabilitation or recovery phase. Okay? Depending on where your injury is what you're going to see in terms of long-term complications. If you have a spinal cord injury down in the lumbar region, you may not have very many side effects left over other than your motor function. If the higher the injury, the more side effects you're going to get. But after 12 weeks, the swelling, edema, secondary injury should be all gone. You should have your spinal stabilization and the bone healing is done. And we can now prognosticate the long-term injury. They won't really do it until about 12 weeks after, because the swelling is going down that whole period. And we are just watching them and seeing where they're going. This is where they start going into physical therapy, occupational therapy, and deciding how to manage their long-term problems. So the things that I'm going to have you pay attention to are the main long-term complications. So if you have a question about a patient that's coming back from rehab into the hospital, or a patient that has been 3 or 4 months out, we're talking about these kind of complications. Okay, they're not longer going to have neurogenic shock. They're not going to have spinal shock. That's over with. Now we're heading into the long-term complications, and the number one is autonomic dysreflexia. And then, of course, if you have a injury that's going to affect your chest muscles, you are at high risk of pneumonia and respiratory infections. And if you have any other spinal cord injury, you are at risk for bladder dysfunction for the rest of your life, and you are at risk for skin breakdown on the non-feeling parts of your body for the rest of your life. And so those are the 4 main complications. These are what's going to kill people. The spinal cord injury usually doesn't kill people. The spinal cord injury will only kill you if it's really up high and you just can't breathe. And you cannot survive without mechanical ventilation. That's the only thing I can tell you from a spinal cord injury. The rest of it, this is what kills you. What did Christopher Reeve die of? Pneumonia. What do most spinal cord injuries die of? Respiratory complications or wound complications. That's what kills people. Respiratory or wound. And wound is a big one because there's going to be some non-feeling skin. So let's go over dysreflexia and then fill in the rest of your grid. And then I think you can do the rest of this. But this is an inappropriate reaction to an irritating stimulus. We kind of talked about it. This happens with a spinal cord injury, T6 or higher, because remember, that's where the sympathetic system comes out, is right around T5. And so any injury higher is going to affect that sympathetic nerve conduction. And so basically it will only happen with T6 or higher, and your symptoms are going to be rapid hypertension, like big hypertension. Your patient's going to look cherry red and sweating and miserable and have a horrible headache. That's because the blood pressure has shot up really fast. They may have bradycardia, they may not. That's not a guarantee. It depends on how dysfunctional the sympathetic system is. But if the sympathetic system is so dysfunctional that it just stops transmitting, you might get that uninhibited parasympathetic. But the 2 biggest are the headache and the hypertension. Those are the biggest. So we're going to go back over to our grid. And I already filled this in during lunch. Increased blood pressure, headache, sweaty, and vasodilated above the injury, cold, pale below the injury. And then they might have a decreased heart rate, and it doesn't affect the respiratory rate. Okay? So the big thing for autonomic dysreflexia is the increased blood pressure, headache, and sweaty, and red above the level of injury. So they are a C6 patient. They are going to be sweaty, red, and vasodilated just in their face. And everything else will be cold and pale. That's just because there is a sympathetic response. It's just not a real good one, but it is constricting the blood vessels. You may or may not see the decreased heart rate. So what do we say? We've already kind of talked about the interventions. What do you want to do for a patient with severe hypertension and a headache? First thing, and stage. Get them sitting upright, okay? So head of the bed up. We're going to say get it sitting upright, 45 and 90 degrees. Let's get these people upright. You can also dangle feet, depending on how easy they are to move. But the lower you can get the lower extremities, the more blood drops to the lower extremities. So getting the patient head of bed up, but if you can get the feet down, that's a great way. It helps with shortness of breath, guys. When your patient's having shortness of breath, you can also do the same thing. Sit them upright, lower their feet. All the fluid will fall down to their feet. They'll get swollen feet, but it'll get stuff away from the heart and the lungs. So it works for everything. But yeah, head of bed elevated, dangle the feet, do whatever you need to do to get that blood pressure down. And then what are we going to do? Look for the cause. The cause could be constipation, urinary retention, clothes. So usually what we do after we sit them upright is strip them and look for, see if the blood runs. And basically you are just looking at your patient and their blood pressure. Like as you remove the cause, that headache, sweating, that painful stimulation they're having will go away. It's just like if you pee afterwards, you're like, oh, yes. It will be a relief. If I was stepping on your foot and I got out of it, you would be like, thanks. It's that same response. That's what we're looking for, remove the cause. So really the easiest thing to do is get rid of any flows, because flows are a big cause. Bladder scan, maybe ask the last time they had a bowel movement. Has it been 4 days? Probably constipation. You can bladder scan them. Are they distended? Are they not? You can do those interventions to try and figure out the causes. So normally we remove all the clothes because sometimes it's a waistband that's gotten caught up. Sometimes, like I said, it's a sock. Sometimes socks roll up under their feet. You know, just little things where you would pull your socks straight. They can't feel that. You don't know what it could be. So generally we try to strip them waist down, just try to get rid of anything, not this. Take a look for wounds. So I would say under the cause, remove clothing. And socks. Socks are a big one. Remove clothing and socks. Ask last VM or look for it. Bladder scan. These are the most common causes. And then wounds or infections. Those are the most common causes. The clothes are too tight, they have bowel or bladder, or they've got wounds or an infection somewhere. Infection can set off autonomic dysreflexia, wounds that are getting infected, wounds that are painful. You learned diabetic foot care, right? Kind of the same thing. Just like people with nerve dysfunction can't feel their feet, neither can paraplegics. So we always need to look for the cause. Don't call the doctor right away, because the doctor's gonna be like, what caused it? You only call the physician if you can't get the blood pressure down within about 15, 20 minutes. You can't find the cause, because if it is infection, you might need further workup. But what we're gonna do, we're gonna strip them down and do a skin bowel bladder assessment. Is what you're going to do. If none of that works to fix the autonomic dysreflexia, then you need to call the physician, because it could be something else that's bothering them. You can get blood pressure meds and find out some more tests, but we're not going to call the physician until we've done all these things first. We can do nursing interventions to fix autonomic dysreflexia because it will get most of the things done. So once you've gone through all those things, you've removed the clothing, they had a bowel movement recently, the bladder scan is negative, and you don't see any wounds, then you can call the physician, because you can't find anything in the most common causes. What would ordered interventions be? What do we want to do that we would want a doctor's order for?
What do you have our treatments eventually?
So basically, I don't even have any interventions on here, because we want to set them up, figure out the cause, and we're just going to call the doc. if we can't get rid of the cause, because that means we need some help in finding the cause. So whatever they're going to do. And what do you think, though, we would be treating in the meantime until we can find the cause? What's the most concerning problem? The hypertension. So you might get antihypertensive med or vasodilator. But really, that's just symptom relief until we can figure out what the heck is causing the autonomic dysreflexia. The only treatment for autonomic dysreflexia is removing the cause. The only time we get an order for anything else is because we need time to drop the hypertension until we can find the cause. And that's usually due to infection. That if a patient keeps going into autonomic dysreflexia because they have an infection, we might need to drop that blood pressure with a vasodilator. But I don't want you to put that down as your first response, because vasodilators and antihypertensives are not the main treatment for this. Removing the cause is the main treatment. So I kind of want to keep you away from calling for orders, because on autonomic dysreflexia, no doctor wants to give you an order for anything. They want to figure out why. Why is he doing this? So we'll say, call provider after 20 minutes. Not finding the cause. And I will leave that open to the provider to figure out what to do from there, because it just means that we need to figure out the noxious stimuli. You did your best, but most of the time you can find it by looking for those 4 things. I think that's it. That's it. We can actually talk a little bit more about, and you can always, I have these little 2-minute videos for you to watch. Just click on the links. They're from the Christopher Reeve Foundation. They're real quick about these disorders. Like I said, because you can prevent autonomic dysreflexia by preventing the most common causes are irritation, pressure wounds, apply frequent pressure relief in bed and chair. What does this mean? Pressure relief. We have that further on in the slide, but how often do we need to shift your position in a chair? Why is it more often than in a bed?
It turns the pressure on your back.
You know, there you go, common sense. When you're spreading your body weight out amongst your whole body and you're laying in bed, there's a lot more pressure points and you can stay on one side for longer. But when you are sitting in a chair, where is all of your weight? Right on your booty. And, you know, some of us are very ample ones, but some of us, as you get more and more into the rehab phase, you probably don't, you're not taking in as much, maybe you're not as bootylicious, but either way, you're going to get pressure on those sacral bones sitting up in the chair, so they need to shift their position more often when they are sitting upright. How many patients do you see sitting on a bed in the chair that we don't move? Lots. Lots. That's very bad. They actually need to be moved more in the chair than in the bed. Now we can see why maybe our patients aren't doing that. But frequent pressure relief in bed chair, this is putting maybe a pressure relieving mattress, a donut, something that's going to change the pressure. Or just shift their position in the chair. Sometimes just pulling up the sheet that they're sitting on, moves their self in the, putting, you know, having them maybe lean forward and shifting some pillows behind them, doing something to shift their position. If they are already in the rehab phase and maybe they're in the wheelchair, they know they set an alarm on their phone for every 20 minutes, 30 minutes, and they just pick themselves up for a minute and put themselves back down. Just a small movement will help with pressure reduction. Avoiding constipation, bladder distension. These patients may be on a bowel regimen. They will be on bladder regimens, and we'll talk a little bit about that. If they are at risk for respiratory infections, so this would be any patient that had those chest muscles involved. Okay, so what were they? Gosh, I don't remember them. T6 and above? No, it's probably anybody with this chest involvement. So what are we at? Chest muscles right around T6, T7. Anyone that has T6 and above, they're going to be having issues with their chest innervation. Their chest muscles are going to be weaker than the general public. Like, they're just going to be weaker. And they are kind of teetering on that respiratory failure at all times because they don't have as good as respiratory muscles. So with these patients, they may need some extra mobilizing secretions. Normally just kind of some chest PT and they'll start coughing or whatever. But a patient with weak chest muscles may need some assist in their coughing. So this is for patients T6 and above that have those chest muscles involved. They are at much higher risk for pneumonia respiratory conditions because they don't adequately inhale and exhale. So assisted coughing is when we physically Heimlich them to like, and they cough. Because you just push a lot of pressure and they physically cough. So assisted coughing is literally making them cough by pushing on the diaphragm. They can also do breath stacking. I actually like breath stacking. I do it a lot when I'm freaking out. It really helps. It also increases your PEEP. But if you take a breath and don't let it, and take another breath, don't let it up, take another breath, take another breath, and take another breath until you just can't take any more breaths. So you can take smaller breaths multiple times in order to make a big breath. So if you can only shallow breathe, they may have to do this breath stacking, which is, and then they could go, so breath stacking does help, but I breath stack all the time. It really does kind of just feel your lungs get bigger and bigger and bigger until they feel like they can't need more and then exhale all the way out. It really does feel good. It's a nice trick, but it's vital for your patients that can't take really good deep breaths. So asking them to do the incentive spirometer may work, but if their chest muscles are weak, they may not get over 500 or 750 or 1,000. They can't take that big breath. And in order to get them to take that big breath, you have to breath stack them. So just tell them, okay, take a breath, hold it. Take another breath, hold it. Don't let your air out in between, and then you will get a nice big breath. And that's the best way for paralyzed patients who can't breathe real strong to take a big breath is by breath stacking. And then if you breath stack them and then do a push, they will exhale all that breath that they stacked and you can get a real good cough. But it is assisted. And they might have to be able to breath stack and they can give themselves a cough. They will be teaching all of this stuff in patients that just have no good respiratory function, may be ventilator dependent. So depending on your muscles and your diaphragm, what's been injured, you may need constant mechanical ventilation. And we see that on the patients that, like I said, have multiple levels involved that affect the chest muscles. So patients that would need to be mechanically ventilated would probably be someone that's maybe T2, T1 and above, because they've lost all their chest muscle innervation. Even if their diaphragm is pulling down, and then they still are going to be using accessory muscles to breathe. So any patient that's lost their chest muscles because they have an injury above that level, they are going to need lifetime support with their respiratory. If they've lost all their chest muscles, if they're like at a level T1, C8, they've lost all their chest muscles. They're going to need extra help. They probably would be mechanically ventilated, or they will need this breath stacking and coughing to clear their secretions. But they're at high risk of respiratory complications because they're not breathing effectively. So just keep an eye on if you're at like a T6 level, once the swelling's gone down, you've retained most of your chest muscles. You might be just a little weak, but not too bad. So it really depends on what level, what muscles you're losing and are affected, and how much of this rehab you're going to need. But if you are a high-level injury, you're going to have a lot more of these complications. So, so that was rehabilitation, that basically keep them mobilizing secretions. There's, for bladder, there are a couple of things, and like I said, there's a lot of things you can do. Neurogenic bladder doesn't mean it's flaccid. You can have two kinds of neurogenic bladder. It just means the nerves aren't working. You learned about all those in block 3 when you did all the GU dysfunctions, all the spastic bladders, or anytime if you have a patient with multiple sclerosis, they might have a spastic bladder because sometimes there's no innervation and sometimes there's a lot of innervation. So you could be a spastic bladder or a flaccid areflexic bladder. So I want you to know that neurogenic bladder does not mean always distension. They could have just basically, and these nerves are always trying to work. And so sometimes they get through and sometimes they don't. So a patient who's paralyzed may have no bladder function, but they can still have incontinence because they can still have spasms, reflexes. They can still do things underneath the surface. So you can have a patient who's completely paralyzed that twitches their leg. And you're like, oh, that's just a reflex. That's something that's happening down there, didn't need the brain. And so it doesn't need the complete connection from body to brain. It's just working on its own. So they can have reflexes. They can have incontinence. They can have some spasms. That's not surprising in a spinal cord injury patient because their nerves are just screwed up. But either way, we never tell the patient to not drink. We always want them drinking adequate amounts, which is about 2 liters a day. They're not going to drink so much that they need to flush. Flushing is like 3 to 4 liters a day, but about 2 liters a day is what we ask people to do. Most of them are on a voiding schedule. Our bladders are really good at knowing, like, if you try to not pee when you get up in the morning, you're not going to be able to do it. Your bladder's on a schedule, and it knows you got to pee when you wake up in the morning. And if you try to deny it, it's going to be upset. So bladders, once they get on a voiding schedule, they will just void when they're ready. Like, I mean, you probably have a voiding schedule, and you don't even know it. But you can put yourself on a voiding schedule very easily. If your body gets used to peeing at a certain time of day, it will pee at a certain time of day. So they can do things for flaccid bladders. You can intermittently catheterize. They can do catheters. They actually have electrical stimulation that, well, every 8 hours, like pacing the bladder, every 4 hours or every 3 hours, it will contract the detrusor for you. It'll stimulate that contraction and you'll pee. You'll know when it's coming. Urinary diversions can actually divert the bladder out to the outside. What do you think would be best for a patient with a flaccid bladder? What would you like to have done? You want to do intermittent catheterization? Do you want to keep a catheter? Should we keep a catheter? No, I don't want you to keep a catheter. It's disgusting. Have you seen long-term catheters? They're nasty. Don't put a catheter. The best way is probably intermittent. You may see some spinal cord patients have those suprapubic catheters. Big drainage issue, big infection issue. Long-term catheters, big infection issue. The reason they don't intermittently catheterize most patients is basically nursing convenience. You're a long-term skilled facility, they should be straight capping them every 3-4 hours. It reduces the risk of infection because it's not an indwelling catheter. But convenience, we do sometimes things to harm patients. Indwelling catheters are not a good intervention. They're constant infection risks. So intermittent catheterization is the best. External catheters are like the PureWick, the, I didn't even write suprapubic or constant catheters because I don't think it should be an intervention. People doing it, it's not good, it's lazy. You should be intermittent catheterizing the patients. The patients can intermittently catheterize themselves or a caregiver can do it. External catheters, like I said, are PureWicks, condom catheters, all those fancy things that don't go inside but wick away moisture. And like I said, you can do diversions or electrical stimulation, but just take care of that bowel or that bladder. Bowel maintenance. The gastrocolic reflex is 30 minutes after your first meal. Everybody thinks they're coffee poops, but it's just a reflex poop. You got to poop after you eat something in, something out. And that is something that is that is a reflex. That's what babies have. That's why they poop while they're eating. It's a reflex. It's something in, something out. And we kind of get control over that reflex as we get older. But we will try to harness that baby reflex later on and say, okay, let's see if we can retrain that when you eat, you have to sit up. And the way you do that is after they eat the first meal a day, 30 minutes later, put them on a toilet. And that brain will start trying to engage the reflex. You might not get full connection, but eventually the body will catch on that it needs to poop after eating. And then you'll be on a toilet. So that's something that they do to get that reflex going. It only works in the morning, but they can try to get it going, but definitely keeping their range of motion. And they may need extra help. And amongst still some, there's suppositories, but we got to keep that bowel moving as well as possible. And skin care, again, every 2 hours while in bed, reposition every 15 to 30 minutes if up in a chair, and make sure they or you, someone is doing a full assessment every day. When you learn diabetic foot care, you're supposed to look at the feet with a mirror, right? All spinal cord injury should have a little handheld mirror where they do a skin inspection, because they can't see all their wounds. They have to be able to visualize all of their skin so they can look for wounds, redness, scratches, things that might become infected. The same as diabetic foot care, but they should be looking at their own skin or having someone else check their skin every day. Every dang day, check and look. Did you get scratches? Did you get sores? Did you get a pressure redness? What are you doing? And stay off of that the next day. But they should be assessing their skin every day and keeping their weight off. And that is the best way to keep your spinal cord patients alive, is by preventing those 4. And that's the end. So, what do we think? We've got a summary. It's 1:10. I'm going to pause.